So today, I've been asked to talk about healthcare, and specifically healthcare policy in the United States, some of its implications for constitutional rights, as well as the economic policy implications of some recent reforms we've seen lately, namely the Affordable Care Act, or better known as Obamacare. So I'm going to try and touch on all of those areas. First, we're going to start talking, basically in this order, we're going to talk about the implication of healthcare and healthcare rights. Is healthcare a right in this country? Do you have a right to care? In the same way that you have a right to free speech or freedom of religion. Then we're also going to get into a little bit of the history of government involvement in the healthcare sector in the United States, so that we can kind of preface our broader talk about the Affordable Care Act. And in that, I'm going to try and explain a little bit of the economics of the Affordable Care Act. Full disclosure, I'm an opponent of the Affordable Care Act. I don't think it's good policy, but I'm going to try and at least convey to you in a fair way as possible, what they were attempting to do with the Affordable Care Act as far as economics is concerned. And hopefully all of this, interspersed in all of this, would be kind of talking about the different decisions that we've seen at the Supreme Court and what those mean for the Constitution and the precedent that the court has set in regards to the specific decisions, King v. Burwell, and of course the original Obamacare decision, which was National Federation of Independent Businesses v. Sebelius. So we'll talk about those interspersed with the other topics. So the first thing we have to discuss before we talk about the economics of healthcare is whether or not healthcare is a right. Do you have a right to healthcare in this country? And of course there are two camps on this. There are people that say, yes, you have a right to healthcare, and then there are folks like myself that say, no, healthcare is not a right in the same sense of some of the constitutional rights that we have provided by the Bill of Rights. So here are some of the main arguments that you'll run into for healthcare being a right. Not all rights are enumerated in the Constitution. And to a certain extent, that's true. I mean, the word privacy occurs in the Constitution as much as healthcare does. But conservatives, libertarians would like to argue that there is an implicit right to privacy, that different parts of the Constitution come together to create a right to privacy, even though it's not specifically enumerated. So people that support healthcare as a right will use some of these following arguments to kind of tie together parts of the Constitution to say that there's an implicit right to healthcare. So one of those things is that good healthcare is necessary for all your other rights. I mean, it's kind of hard to pursue life, liberty, and happiness if you're sick. Free speech, freedom of religion, all those things don't matter very much if you're dying of cancer and you're not getting care. There's also, in the Constitution, promote the general welfare. It's listed, it's written twice in the Constitution, and promote the general welfare, that power is given to Congress in Article 1, Section 8. And if you pulled 100 people off the street at random and asked them, do you think promote general welfare can be used to justify a right to health care, I'd bet about 90 to 99 of them would say, yeah, oh, that makes sense to me. And finally, you have arguments such as education, fire, police. All of these things are provided by the government. You pick up the phone, the fire department will show up, police officer will show up. And if you need a desk to go to school, I mean, you can buy private education, but in many communities you are entitled to public education. So why aren't you entitled to public health care? So these are the main arguments that you're going to run into. I mean, I'm sure there's some more nuanced arguments out there that really get in deep into philosophy and stuff. But when you turn on the news and you even watch some liberal programs or progressive programs, these are the arguments that they're harping on. So these are the arguments against healthcare as a right. And it really comes down to positive versus negative rights. Does anyone know what positive versus negative rights are?
Yes.
Would anybody volunteer? Go for it, I saw your hand.
Your negative rights are like your natural rights, the kind of unspoken rights, whereas positive is like more physical stuff.
Yeah, that's pretty close. Positive and negative rights, I mean, the specific definition for positive right is an obligation of action, and whereas a negative right is an obligation of inaction. So an obligation of action would be, say in country X's constitution, you have a right to a free pony. That would be a positive right. The government must provide you with a pony. You're entitled to one in this, your human rights in this country. So you can kind of take that and insert healthcare. You have a right to healthcare. That would be a positive right. You are entitled to the government giving you something or engaging in a certain action. Whereas a negative right, I mean, this isn't to be confused with good or bad. A negative right essentially says that your rights are secured by the government not doing something. So if you think about the First Amendment or any of the other amendments of the Bill of Rights, it isn't you have the right to free speech, you have the right to freedom of religion. It is Congress shall not abridge, or they shall pass no law that abridges these rights. So it's essentially saying that Congress the government cannot do these things. So that's the difference between a positive and negative right. And right there you can kind of see how healthcare doesn't fit into the negative right paradigm that we have here in the United States. One of the few positive rights that you do actually get from constitutional law is the right to legal defense and the right to a speedy trial. Those are positive rights, but those are only triggered when the government is threatening to take away your other rights, or you have been accused of a crime and you have threatened somebody else's property, life, liberty, etc. So that's really one of the only instances where you see the government providing something as a human being. And then beyond the philosophical side of it, there's really the economic side. Rival versus non-rival goods. Does anyone know what that distinction is?
Like the concept that competition within a market will drive goods to be better, whereas if there's no competition, you set no standard for bettering yourself.
Yeah, I mean, the competition is the key thing there. You think about rivalry, competition. So a rival good, for example, would be, say there's a candy bar. If I eat that candy bar, you can't. I've consumed it. So there would be a competition because there's a finite resource, and my consumption of that good limits your ability to consume that good. Whereas a non-rival good would be something like air. If I'm breathing air, it doesn't, apart unless we're traveling to the moon or something in an enclosed space, my breathing air doesn't take away from your ability to breathe air. And so when you put this again into healthcare, in the view of healthcare policy, if there's one bed left at a hospital, and I come in with a broken ankle, and then an hour later you come in and you're having a heart attack, I've already consumed resources that could have been available to you. I've already consumed medical equipment, I'm occupying that space in the hospital, I'm taking time away from the doctors and healthcare professionals. You may still get treatment, but you will not have access to as many resources because I've been consuming that good. So an example of a non-rival good would be national defense. Because the nation is defended by the military, me being here doesn't take away from your defense, right? So we're all sort of equally defended there, and my existence doesn't take away from your ability to be defended by the military. Whereas with healthcare or any other resource, and we'll get to this in a second, scarce resources, that is a rivalrous good because, like I said, if I'm in surgery and there's one surgeon in town and you come in needing surgery, to say that healthcare is a right would mean that you now have legal recourse against the government simply because there weren't enough resources. So that creates a lot of problems. And we have to also accept that if we're going to argue in this healthcare debate, we have to accept that education, fire, police, these are not actually rights. These are goods that are provided by the community. You think about police are really there to protect your other rights. The fire department, they'll come and try and put out your house, but their main goal is to make sure that the rest of the neighborhood doesn't burn down. And you don't have legal recourse if the fire department can't prevent your house from burning down, because you're not entitled to the fire department completely preventing your house from burning down. And then, again, education, that's a kind of a tricky one because government has been providing it for so long, but again, it is a good, and just because the government is now providing it doesn't mean that it is a right. And we've seen, and I'm sure you've heard from a number of different speakers, that there are a bunch of problems already occurring with government education, and you're finding that you're running into some of the same problems, whereas if you don't have an education, it's not necessarily as severe as if you're dying of a heart attack. So the problems don't rise to the level that you would see in a debate versus healthcare versus education as rights. And finally, scarce resources which have alternative uses, which kind of encapsulates a lot of this, is that, once again, there's a finite amount of doctors, beds, medical equipment, medicine, and so that requires an efficient allocation to do the most good. And generally you don't see that when the government is providing something as a right. And so the study of the allocation of scarce resources which have alternative uses, a little bit of jeopardy here, is the definition of, anybody? It's the definition of economics. So economics is defined as the study of the allocation of scarce resources which have alternative uses. So moving on, once you're able to have this debate as whether or not healthcare is a right, you can kind of get into the economics and policy of it all. So the history of healthcare reform. Why do we have health insurance? I mean, you don't have clothes insurance for all the other goods that you buy. You don't necessarily need insurance for a lot of the things in the economy, but we have health insurance. And why is that? Why is healthcare so expensive? Well, it really started in about the turn of the 19th to the 20th century. You started to see a real rise in healthcare innovation. For many, many centuries throughout human history, healthcare was very basic. They couldn't do much for you. George Washington died because they bled him to death, and they thought that was going to cure him. So you started to see a rise in healthcare innovation. Humans were starting to get good at fixing things and curing diseases. And with any innovation, think about the cell phone, the first cell phone that came out, very, very expensive. But the problem is that there's a big difference between the demand for a cell phone and demand for healthcare. You can delay the purchase of goods and services, but it's hard to delay the purchase of healthcare if you're really sick. So you started to see a really huge rise in costs. And that created the health insurance industry. Once again, you can't really predict when you're going to need healthcare. But you can predict when you're going to buy other goods and services. And you have a little bit more control over that. So the insurance was a way of basically hedging against those instances. So that's where the insurance industry came from and came to kind of dominate healthcare. In World War II, basically there were wage controls. This is part of the New Deal and it's also part of World War II. The government took over and basically set prices for almost everything in the economy, including labor. And so companies couldn't compete for scarce labor because everybody's going overseas to fight. So there's a scarce amount of people left that are in the labor market, and we're trying to produce tanks, airplanes, stuff like that. And so these employers couldn't compete by offering more pay because the government fixed it. So what they did is they, instead of offering additional salaries or hourly wages, they offered you health care and other fringe benefits. And the IRS basically looked the other way on this and has ever since. And they said that, yeah, this is tax deductible, we can't tax this form of compensation. So if you think about a simple math problem, an employer is going to pay you $10,000 more. That $10,000 means the same to the employer no matter what. But if there's a 25% tax rate, basically you're only going to get $7,500 of that. But if he offers you $10,000 with health insurance, you get to basically keep the entire value of that $10,000. And because there's such a demand for health insurance, it's more advantageous for you to take that, if that makes sense. And that's really driven the employer model ever since. And the majority of the country that is on private insurance gets their insurance through their employer. But this created some natural problems as time went on because not everybody has a job, particularly old people and sick people that can't work. So what was the government going to do about these people? And in Johnson's Great Society in the 1960s, that answer was Medicare and Medicaid. They're very similar programs, but they're both single-payer programs. So you hear this term single-payer about healthcare, where that is one person basically, or one organization pays the bills. You go into the hospital, you get treated, and you walk out, and they send the bill to the government. That's single-payer. And so that's what Medicare and Medicaid are. Medicare is for retired people, naturally because they didn't hold jobs and they no longer were covered by employers. And Medicaid is generally for people with disabilities, people with dependents. And that has since changed because of the Affordable Care Act, but we'll talk about that in a little bit. So where are we at today? What prompted Obamacare? Why are we having this conversation, and why was this major overhaul of the healthcare system passed? Well, if you look at this chart, and I hope everybody can kind of read it, but I'll explain it. This is price inflation across different sectors of the economy. The top one there is education price inflation, which most of you will be feeling very soon. Medical care has outpaced inflation really ever since the 1960s. That means prices are rising. You're spending more dollars and not necessarily getting any more marginal utility or benefits out of what you're paying for. Whereas other sectors of the economy, auto repair, here's the example listed, is really kept pace with inflation. That dotted line at the bottom there is basically the consumer price index, or how the government measures inflation. And so this has created a real problem, and especially created a problem with the financial crisis in 2008. Naturally, a lot of people lost their jobs, so they lost their insurance. And so you created a real large political constituency of people demanding action on healthcare. And so that's kind of where we're at today, or where we were at in 2009, 2010 when the Obamacare debate started. So Obamacare, just a brief overview of basically what it is. Formal name is Patient Protection and Affordable Care Act. So if you see PPACA or ACA or Obamacare, it's all the same thing. That's what they're talking about. It's important to distinguish though what Obamacare is and what it isn't. There was a lot of fear when this law was being debated in Congress that it was going to be another single payer system, or a single provider system like what they have in Europe. So you would go to Great Britain, they have a single payer provider system where the government owns the hospitals and the hospital workers are government employees. That wasn't the case under Obamacare. There's still private hospitals, charitable hospitals, and it's not entirely a single payer system. There are some subsidies and an expansion of Medicaid, which we'll talk about, but still there was this large component of private insurance companies actually paying the bill for the provision of health care. Obamacare is pretty complex. When it was passed, it was about 1,000 pages. At one point, it was about 2,000 pages of legislation. The final version that passed was about 1,000. And since then, all the regulations that have come along with it have totaled about 70,000 pages and counting. So that's just for one law, so it's a doozy. But these are basically the 5 things that Obamacare does, and if you're going to have an intelligent conversation about the law, these are the things you're going to want to know. So first off is, of course, the individual mandate, and this has been the most controversial provision of the law, or arguably the most controversial provision. Basically, as of last spring, everybody in the country has to have coverage of some sort, period. You got to have Medicare or Medicaid, you have to have private insurance covered by your employer or something, or else you get a fine. And that fine is enforced by the IRS via withholding your tax return. Or they basically bill you in addition to your taxes if you aren't owed a return. And that's the structure there. It was about 1% last year, and then it's bumped up to 2%, and it keeps rising. I don't have the exact figures for 2017, 2018, but the fee continues to rise year after year, so it's designed to push more people into buying health insurance. And basically you pay the lesser of either of those costs. If you can't prove to have health insurance. But you can't just have any health insurance to qualify for this. The government has set minimum standards for what qualifies as health insurance. And that is what's caused a lot of the cancellations. I'm sure most of you have saw the news stories where everybody's, when Obama said, if you like your plan, you can keep your plan, and then millions of people started getting cancellation notices. And the reason why is mostly these minimum coverage standards. There's basically 10 things that all insurance plans in the country have to cover now. And a few of them are very basic, like hospitalization. Okay, no-brainer. But a few of them are causing a lot of problems because some of them are basically maternity care. Now, I'm an unmarried guy without kids. I don't exactly need maternity care. So if I had had an insurance plan before Obamacare, I wouldn't have purchased something like that. And so then my plan would have been canceled. Or you have retired people that don't plan on ever having kids. They would have to purchase maternity care. There's also pediatric vision and oral care. It's required to be covered by every plan in the country, whether or not you have kids or not. So naturally that led to a lot of people getting their plans canceled. They estimate about 5 million, we know for sure, upwards of 10 million once all is said and done, because not every single state is tracking the number of cancellations that they have. But even the administration estimated about 10 to 15 million would get canceled. And this is just in the individual insurance market. And so the individual mandate led to the case National Federation of Independent Businesses, what NFIB stands for, versus Sebelius. Sebelius was, at the time, Secretary of Health and Human Services, which oversaw the majority of Obamacare. And basically, they filed a lawsuit saying this is unconstitutional. You can't force an individual to buy a private product with the power of taxing. Supreme Court, unfortunately, as we all know now, disagreed. And the swing vote was Chief Justice Roberts. And there's still a lot of debate about that, and I don't have a good theory for you as to why he did it. But one of his main excuses for doing that was that it can be labeled a tax because it's not as strong enough of a tax to be able to force you to buy private insurance. I don't know how well that argument's going to hold up over time. And one of the constitutional implications now is that there is precedent for the government being able to force you to buy a private product. And if you take economics and you start talking about rent-seeking someday in an economics class, that becomes a big problem because people are going to use the coercive force of government in order to ensure markets for themselves. I mean, if you own an auto dealership that sells Fords and wanted to sell more Fords, it'd be great if there was a Ford mandate, wouldn't it? So now you have the insurance companies, they love this now. They initially opposed it, but now that they have that cornered market, they're gonna fight hard against a repeal of this. So that's some of the constitutional implications of that first major Obamacare decision. The employer mandate is the other part. Basically, large employers have to cover. That's the penalty structure. They face the similar standards. So basically, you have to have those 10 essential health benefits, and there's a couple of other math calculations they do as far as premiums paid versus benefits paid out that you have to reach. And those are moving targets every year, so people can see their plans canceled over and over again as time goes on. But the big problem with this is that it creates a marginal disincentive to hire or provide coverage. So if you employ 49 people, you don't have to provide any health care coverage for them right now. But if you decide to hire one more person, I mean, potentially thousands and thousands of dollars kicks in fines or required costs for health care. And so you create a really huge marginal disincentive to expand your business beyond 49 employees. And you also, this is, again, I mentioned here, full-time employees. What you're seeing is a lot of employers are cutting people back to part-time. And part-time has been redefined under the Affordable Care Act from 40 hours a week to 30 hours a week. So you're seeing a lot of people losing almost 10 hours that they get every week, which is huge. I mean, it's a 25% pay cut for some people. Because now this is the incentive structure. It's a perverse incentive economic structure that the law creates. So the next big part, and these are probably the most popular things that are in the law, are all the insurance regulations. And most of you probably know standing parents insurance until you're 26. Some insurance plans used to have lifetime limits. That's gone. So you would be covered for X amount a year, but if you exceeded that over several years, they could cut your plan. Bans rescissions. So basically, if you're diagnosed with cancer while you have insurance, the insurance company can't take your insurance away. Medical loss ratio basically enforces how much of your premium has to go towards healthcare. So basically, it's between 80 and 85% of what you pay the insurance company has to end up paying for your healthcare. It can't go towards the insurance company's power bill or their payroll costs or things like that, or their profits. And finally, it eliminates, this is the big one that's kind of the rest of them are fairly popular and non-controversial, aside from the fact that they raise costs. The final thing that's pretty difficult is the elimination of risk rating. So basically, if you go to buy a car and you haven't paid your credit card bill in 2 years, they're not going to give you a very good interest rate, or they might not loan to you at all. So their interest rates are basically a measurement of risk in the economy. By eliminating risk rating in insurance, basically insurance companies used to be able to look at your health background. Are you a smoker? Well, they can still look at that now, but you know, what type of health history does your family have? Is your family predisposed to a certain type of cancer or diabetes, things like that, things that would impose a lot of costs on the insurance company and make you very much more likely to draw on insurance. And this was a way to sort of hedge against that risk, that they could adjust your premiums for that. They can't do that anymore. And so that creates a bit of a problem if a lot of young, healthy people that aren't sick don't sign up, because then you have a lot of people that are guaranteed coverage that may be really heavy draws on the insurance pool. The only things that they can judge for is whether or not you're buying for your family or not. Geographic, so there's different health costs across the country, and things cost different in different states. Your age, and the age one is particularly important for you young people to know, because they cannot charge older patients 3 times more than they charge younger patients. Now that's not a mechanism to keep your costs down. That's a mechanism to keep old people's costs down, because young people generally don't draw on insurance very often. And so it gets you into paying into the system in order to subsidize the costs of people that draw on the system a lot. So it's basically, unfortunately, it's kind of a wealth transfer program from young healthy people to old sick people. That's the way it actually works. And finally, you can charge smokers twice as much. That's about it. That's the only thing you can discriminate against when issuing health insurance. So the exchanges. This is pretty much how those went. Websites did not work. And so basically, there were several states had the option of whether or not to set up an exchange. The exchanges were these clearinghouses for buying insurance. They were all websites, essentially. And this got a lot of news attention because almost none of them worked. I mean, a few state-run exchanges, because states had the option to basically set up their own or let the federal government pay for one big one. And most states let the federal government buy one big one. and set that up, and that was healthcare.gov, and that barely worked. And unfortunately, that creates a bit of an economic problem as well, beyond how much a really expensive website that doesn't work costs. The problem is that the people that were willing to wait through the website and dig through all the bugs and get on the phone are the people that need healthcare the most. The older people, the sicker people. And that means that you have risk pools now of people that are disproportionately more sick and older and are going to draw on the plans more, which means that the price of the premiums is going to go up for everybody else. And the other problem is, too, this wasn't just a federal issue. A lot of the state exchanges have gone completely over budget. Even states that are totally on board with this, like Oregon, blue state, totally on board. Their exchange went hundreds of millions of dollars over budget and it doesn't work. And they've since basically asked the federal government to come in and take over. So the final big part is subsidies in the Medicaid expansion. So Medicaid, like I said, is a single payer program for poor people that can't afford insurance, basically. And it's been expanded underneath Obamacare to basically pay for anybody under 138% of the federal poverty line. And it didn't used to be that way. There used to be special qualifiers. There used to have to be special circumstances that made it, made you a needy case for getting Medicaid. At this point now, basically you just have to be under a certain income level. And unfortunately, the majority of the people that have been covered now by the Medicaid expansion have been childless adults that can work. So basically, you're people that could go out and get a job but haven't and don't have any reason to stay home are now getting their insurance covered almost 100% by the federal taxpayer. And that's the other important part about the Medicaid expansion is that Medicaid, prior to Obamacare, was basically this cost was split between the state government and the federal government. And depending on the state's poverty level, the government would chip in. It was about 50-50 in most states. So states paid half and government paid, feds paid half. To get the states to do the Medicaid expansion, for the first 3 years, the federal government promised 100%. We'll pay 100% of the costs. So states said, well, I have no incentive not to take this, not really realizing that all federal money comes from state taxpayers, but that's a whole other can of worms. And then after 3 years, it goes down to 90%. And so you can be sure as Congress, facing increasing deficits in years to come, looks for ways to cut costs, they're going to start shouldering more of that burden on the states. And so states are going to have to really pay for their decision to expand Medicaid. And finally, the subsidies. So the subsidies work with those exchanges. That's why they established the website. Basically, the federal government is going to help you pay your insurance premium for a private company, through a private company. And that 76 means that 86% of people that went on the exchange to buy healthcare qualified for a subsidy. And the average subsidy that they got was 76% of their costs. So essentially, you have a bunch of people now signing up for private insurance, and although Obamacare is not supposed to be single payer, it's become majority payer, where you have, 3/4 of people's costs now being shouldered by the taxpayer. And the big problem with that is that they estimate upwards of 2/3 of the people that signed up for Obamacare already had private insurance. So they were buying insurance on their own, could afford it, but now we're paying for it. So that's kind of a big problem that we'll get to about federal financing, deficits, and long-term debt, because those are obligations now that under law are owed to people. King v. Burwell was the big case that got decided recently, another unfortunate kind of stab in the back from conservatives on the Supreme Court. And basically the crux of this was the text of the law says that the subsidies are only available in states that establish exchanges. And essentially that was sort of a carrot for these states to set up their own websites. Otherwise they really didn't have an incentive to do so. And the guy that designed most of this law is an MIT professor named Jonathan Gruber, who I'm sure a lot of you have seen. He made himself a little famous by calling everybody stupid on camera. Not really a good thing to do when you cost the taxpayers $2 trillion to call them stupid, but anyway. He was on camera essentially saying, well, if the states don't establish their own exchange, they don't get the subsidies. It's clear as day that it says that, and in several places in the law it says this, established by a state, established by a state. And the Supreme Court basically reinterpreted the law and saved it from itself and said, well, there's no way Congress would have ever meant to do this, because without this, the law would fail. So we're going to ignore that and assume that an exchange established by the state applies to the federal exchange as well, even though there's a lot of glaring differences. I would encourage you, if you're interested in King v. Burwell, read about the case, but read Justice Scalia's dissent on this case. It's, there's a little bit of legalese in there that's hard to get through, but a lot of it's very clear, where he explains why that decision was ultimately wrong and kind of explains the conservative position on this case. But so it stands now, we owe subsidies to people in all 50 states, not just the states that established exchanges, which was very few of them. So here I'm going to try and explain what they were trying to do with Obamacare. And everyone familiar with the supply and demand curves? Just to brush anybody up, basically P is price, Q is quantity. The higher the price, the less people are going to demand, so lower quantity. The lower the price, the more people are going to demand. The higher the price, the more the producer wants to supply. The lower the price, the less the producer wants to supply. So I think it's pretty self-explanatory there. And this is important to remember these concepts because we can illustrate essentially what they were trying to do with the Affordable Care Act. So if you look at point Q, the first point there under point A there, that means that is where the market was. That was the quantity of health insurance in the market. Now that wasn't the socially optimal quantity of health insurance in the eyes of the government. More people needed to be covered, and certainly there were a lot of uninsured people. So they wanted to get to Q1, which is the socially efficient allocation. And that is the better allocation because there is a positive externality for you to have health care. You don't get sick, you don't make other people sick, and you don't pass off your costs, uncompensated costs, to the taxpayers or the hospitals. So there are benefits that aren't captured and you don't pay for when you buy health insurance that other people capture. And so essentially, what they were trying to do is capture those benefits of expanded health care insurance for people that didn't have it. And that is the MSB line there, which would be the marginal social benefit. But to do that, essentially, the costs, what people were willing to pay and what society was willing to pay for health insurance didn't match up with the quantity that was needed. So what did they do? They spent a bunch of money to raise P to that second dotted line there. And what that does is essentially shifts the benefit curve, which is also a demand curve, to meet the marginal social benefit. So the private costs and the costs borne by the government therefore equal the benefit to society. So that's what they were trying to do. And without doing that, you get the point, the CAB triangle right there that's highlighted, the welfare loss. That's considered a deadweight loss for anybody that takes economics. That's what that is. So if you take any economics courses, you're going to see stuff like this. And what that's called is a Pigouvian subsidy, named after a guy called Pigou. So that's what they were trying to do. But unfortunately, what they did was this. The demand curve became inelastic. So elasticity and inelasticity, you think about a rubber band, right? The rubber band is elastic. It responds easily to pressures, right? You stretch it, you compress it, it responds easily. Now, a rock is inelastic. You got to exert a lot of force to change a rock. And so demand can be elastic or inelastic. It can be responsive or unresponsive. And what you do by essentially guaranteeing that you're going to help people pay for their health insurance and mandating that they have it is you make the demand curve inelastic, which means this straight up and down line here means it doesn't respond to P. Q doesn't respond to P in the economics terms. And so essentially what happens is that you create an incentive for insurance companies to raise their prices because they don't have an incentive to keep them low. Because the government guarantees payment and you have to have health insurance. So why wouldn't you buy it? And so that has resulted in increasing premiums. From 2014 to 2015, there's a study by the Manhattan Institute, you can look up, that showed a 41% average increase in premiums from 2014 to 2015. These are premiums, I took this from a Wall Street Journal article, these have just come out in the recent months, basically showing these are requests that insurance companies have put in for how much they want to increase their premiums. Some are very low. In the northeastern states, they already have very heavily regulated insurance markets as is, so their premium increases are only a few percentage points, if at all. But in some of the other states without having insurance regulations, you're seeing really high costs. You're seeing these new benefits that I was telling you about have to be paid for. And that's what results in these double-digit increases in insurance premiums. The administration has come out and said, well, these are just the requests. They have to go through the insurance commissioner and they have to be approved by the insurance commissioner. And that's true, but like I said, Oregon, another state that's really on board with this law, their insurance commissioner has approved a 25% increase already in premium. That's in 1 year. So Affordable Care Act's not really holding up to its name. So the reason why we're concerned about this is because we're already spending a tremendous, I cannot emphasize how much money we spend on healthcare in this country from the government, and we just shouldered a heck of a lot more. So basically, this is where the dollar goes. Every tax dollar that goes to the government, this is where it goes. 66%, nobody debates, can't be debated. Government has no control, essentially, unless Congress passes a law changing the formulas, has no control over where that 66% goes. And that's in 2014. So welfare, Social Security, Medicare, Medicaid, and other health programs. That's 66% of every dollar. Everything else you hear about, everything else that gets debated, roads, schools, NASA, everything fits in that 34%. And that's not just what the government spends, that's the dollar, because the government's running deficits. And so this is going to continue to grow. And as this chart, I took these charts, by the way, from the Heritage Foundation. You're going to want to go to their website. They have a great resource. It's called the Budget Chart Book. And they do these every year, and they kind of, with the new calculations, make these great graphs. So I want to give them credit for that. This is a projection out into the future on current law. So if nothing changes, this is what's going to happen. And essentially, historical revenue averages about 18% of the economy. And by about 2030, all revenue to the federal government will go to paying off interest on the debt, because interest rates are scheduled to rise, so interest payments become more expensive. Right now we spend, I think, 250-something billion a year. Interest rates are almost 0% right now, and we spend about 250 billion paying in interest a single year. So that's a lot of money. So basically every dollar that we raise in taxes will go to these 4 categories by 2030. That's not that far away. I mean, if you really think about it, it's 15 years away. Where basically everything else, including national defense, will have to be paid for through debt, unless this changes. And again, included in that, Obamacare subsidies. And you can see that this line here is about when Obamacare was actually passed and went into effect. And that section gets a heck of a lot thicker. So this is the projected deficit. You'll hear the president talk right now like, oh, deficits are at their lowest level in 5 years. He's right, but they're coming down from the levels that he set that were absolutely off the charts. So it's kind of a bad argument to make that. But within the next 5 years, deficits are projected to go back up again to about $1 trillion every single year. So you think about the national debt is about 18 trillion right now. We'll be adding $1 trillion to that every single year by 2025. This is a little bit out further towards 2090. That's deficits per year in inflation-adjusted dollars for 2014. That's $12 trillion in deficits every single year. So you'd be adding our entire national debt right now every single year by 2090. So these are the actual numbers. Debt held by the public. So this is when people are like, oh, China owns our debt, or all these other countries own our debt. That's what they're talking about. But it's not just China. China owns about $1.5 trillion. It's private companies, private individuals. They basically give the government money, and the government gives them back bonds. And those bonds have a fixed amount that they're promised to pay them when they mature. And so that accounts for a significant portion of the actual on-the-books debt. $5 trillion is intergovernmental debt. What that means is that's debt so parts of the government are borrowing from other parts. And huge part of that is the Social Security Trust Fund. So basically, by law, all the money that goes into Social Security doesn't just sit in a bank vault waiting to be used. It's immediately given to the government and is borrowed by the government and is counted as a general revenue. And so that $5 trillion, a lot of that is money that is being promised to people under Social Security right now and is actually on the books. That's money that's flowed into the Social Security Trust Fund. And Obamacare over the next 10 years, and this is why we're kind of concerned, is We were already facing these problems in 2010. And then this law passed, and it's conservatively going to add 1.3 trillion to the debt over the next 10 years. And those are only going to rise because, like I said, basically the economics of it is that insurance is going to continue to get more expensive, and the government is going to continue to be liable for more and more insurance payments and subsidy payments. And there's really not a whole lot of cost controls in Obamacare that have proven effective at suppressing the cost of actual health care. So we're, forget insurance, we're talking about doctor payments and medicine. Actually, Obamacare makes those things more expensive. There's a 3% tax on all medical devices. So essentially, trying to make healthcare more affordable, they put a 3% tax on it, which didn't really make sense. But they're trying to repeal that. A lot of Democrats are trying to repeal that, so that'll probably go. Unfunded liabilities. So that's 70 to 200 trillion that you can add to the national debt, depending on how optimistic you are. And where you get those numbers is that Social Security, Medicare, Medicaid, and now Obamacare, those payments have a formula, and you can input numbers into that formula. You can input your projections about the population, the GDP, where we're headed, and what's owed to people. And you can put those numbers in, and they'll spit out calculated numbers for how much we'll owe in the future. And conservative estimates put it down around 70 trillion. So our national debt right now is 18 trillion. And if you paid the national debt back $1 every second, it would take over 500,000 years to pay. Because that's one thing you need to emphasize to people is that we keep talking millions and billions and trillions, and those numbers, they don't mean anything to people anymore. But, you got to think, a trillion is 1,000 billion, right? So, so that's where we're headed. And that's why people are really concerned about Obamacare. It's not that we don't want people to have health care coverage. It's that we just frankly can't afford it. We can't afford the people that we're already paying health care for right now. Medicare is the biggest part of this unfunded liability. It's about 40 trillion on the conservative side. And that's health care payments just for elderly people because our population is aging with baby boomers retiring and stuff like that. But there are things we can do. So it's not all hope is lost. This stuff hasn't happened yet. This is just assuming that these changes don't get made. And so the ultimate solution for the healthcare crisis in our country is really get away from this insurance model. Right now we keep having these debates about healthcare insurance, how we're going to insure people in this country for healthcare. But nobody really realizes outside of some economic circles, and more and more people are really starting to wake up to this, that insurance is the ultimate problem. Because there's no market forces when you have insurance. You don't really care how much your health care costs if the insurance company's paying for it. So you're not frugal. You use as much of it as you want. The TV show host, John Stossel, if you watch his show, if you're familiar with him, he does a great example about this where he goes to a grocery store and says, I've got grocery insurance. I'm just going to buy steak. I'm going to buy lots of steak. I'm going to buy all the most expensive stuff because I don't care. No matter what, it costs me $20 for a co-payment or something like that. And so that's where you really see the rise in healthcare costs. And if we go back to a chart that I had earlier, I can show you a similar thing is happening in the higher education market. It's not insurance, but it's loans. Student loans. You don't see the cost of a student loan until maybe 5-10 years after you graduate. So you don't really think, kids aren't thinking when they select colleges. How many of you are really considering cost and bang for the buck? Oh, that's good. You need to. But yeah, but still, there's a big problem with the number of students where they're not looking at the cost. And universities are starting to build things that are just trying to attract students because they get a blank check from the government. And the same sort of thing is happening in the insurance market because the person that is receiving care does not see the price of it. So ultimately, the solution would be, when you see the price of anything else, like auto repair, you can shop around for auto repair, and that's why it's kept pace with inflation. So some of the solutions are basically these principles. Empower patients and deregulate. Healthcare, everyone says, oh, well, the free market destroyed healthcare. We haven't had free market healthcare since the probably 1960s. Haven't had free market healthcare. We've had a heavily government subsidized, heavily government regulated healthcare market, where doctors are subject to all sorts of rules, and they're subject to also a big problem, a big threat from frivolous lawsuits. Those costs add up. And there's also a huge cost of actually dealing with all the different insurance companies. They say some doctors' offices spend almost 20% of their revenue on just complying with insurance. So you find that more and more people are starting to pay cash. And if you actually call up a hospital and you're about to have surgery, you can offer to pay cash and the cost will actually be lower in a number of cases. And there's a lot of hospitals opening up and doctors' offices opening up that say, we don't take insurance, because it's just too much to deal with, especially with the Affordable Care Act. And there's no reason why, apart from catastrophic things like having a heart attack or things that you can't expect, where you wouldn't be able to shop around. I've got a bad ankle right now, and theoretically it's not ending my life, but so I should be able to shop around. But people don't do that. They just go to the nearest person, the nearest orthopedic, and they get whatever surgery, and neither the doctor or the patient sees the cost. And so you really got to start putting, healthcare is really the only thing where you go in and you don't see price tags. You don't see, it's not like McDonald's where it's like, oh, you can get a Big Mac, it costs this much or that. If you applied that pressure to healthcare, costs would drop dramatically, and that's not just a theory. Because there are parts of the healthcare sector that do not, insurance doesn't pay for it. LASIK, cosmetic surgery. Insurance doesn't pay for those things in large part. And costs have been dropping dramatically. Yeah, they're still a little bit expensive. But as opposed to everything else, costs are going down, whereas healthcare that's covered by insurance, the cost is still going up. Pretty much anything in the economy. Yeah, when it first comes out, yeah, it's expensive. First car was expensive. First cell phone was expensive. Everybody in this room has a cell phone, I would guarantee it. A cell phone that could do a heck of a lot more than the first one. And so we need to apply those same forces to the healthcare sector. Finally, you need to promote, because yeah, you can't shop around if you're having a cardiac arrest or you're having a stroke. Just that's not feasible, and that's the main argument they kind of throw at us when we pitch free market healthcare. Is, well, what if you're having a heart attack? Can't you shop around with that? Well, that's why you have health savings accounts. And you can switch a lot of these entitlement programs like Medicare and Medicaid to voucher systems, where instead of the government basically getting a bill from the doctor, the government sends you that money first. And that's your money. Right? That's a voucher that you have, and if you don't spend it all, you can put it into a health savings account, put it away for a rainy day for you. You can spend it how you want. Spend it for your kids, leave it to your kids, and the government can't touch it. And that would help, at least in part, apply some of the economic pressure that we want to see. Again, supply and demand curves to the healthcare sector that we don't have. And finally, if we're going to emphasize insurance, let's emphasize catastrophic insurance. That way you have something there when, yeah, you go beyond what's in your health savings account, or you go beyond what's in your bank account and pay for it. That's an important thing to have, but what happened under Obamacare is they created a disincentive against catastrophic insurance. They essentially created price levels and regulations that said, well, actually, no, you need to have comprehensive insurance. And while that's going to make the problem a little bit better for now and for a lot of people, in the long run, we're just going to have the same sort of problems. And they're probably going to get worse because we're going to have increasing government control over payments in healthcare. And that really gets away from the incentives that we need to drive costs down. So that's what I have for you. These are our websites if you're interested in some of the research that I'm doing at American Encore. We produce videos and white papers and policy papers, blogs, op-eds, news hits, stuff like that on all sorts of economic policy, and also First Amendment policy as well is something that we work on. So follow us on all those, and if you'd like to open it up for questions. Thanks. Yeah, thanks. Appreciate it. Oh, no.
All right. So say if the federal government does have to get involved, would it make sense instead of having state by state have their own insurance rules and regulations? What if we actually took away those borders where all of these insurance companies are able to play on the same field and the same rules? That way we can actually drive. Cause I don't know if it'd be the same thing. You tell me, you're the expert. My family owns a construction company, and they're always trying to bid for business and everything like that. Do you think it could create that same effect? That way we don't see these giant heaps of premium and just keep astoundingly rising?
That's a problem that's actually we've had. And a lot of conservatives, they'll jump out and say, well, let's let people buy insurance across state lines. I agree. I think that would be great. We have a national market for car insurance. You can see a progressive ad in all 50 states. but you don't really see that with health insurance. In Alabama, for example, before the Affordable Care Act, one company had 95% of the market. 95% of people in Alabama were on one company. So that's not really going to bring prices down. But you're absolutely right. The difficult thing there is it would be good to have a national minimum standard, but that minimum standard shouldn't be massive. And that's kind of what Obamacare has done, is that, yeah, it set a uniform standard nationwide, but that standard's puts upward pressure on prices because it also controls a lot more things than what you have to get covered, like vision care and stuff like that. It controls basically where insurance companies can spend their money. And those things constrain insurance companies' abilities to compete. Because basically what Obamacare did is said, this is what an insurance plan looks like. All of you companies have to offer the exact same thing. And that doesn't increase competition. So you need to have, yeah, I would say a national regulatory standard, but a loose one, so that companies can innovate and figure out ways to provide the most benefits for the lowest cost. So I promised you one.
Would decreased cost of education, specifically medical school, help decrease the cost of healthcare?
Oh, sure, yeah, and we're running into a problem right now where a lot of kids are saying, like, is it really worth it to go to med school for 8 years or whatever it takes and spend all that money going to debt? And then I go into the healthcare sector. Some doctors are only getting $6 or $8 a patient per hour through Medicare and Medicaid. And so this is one of the smartest people in the world, a doctor. He's gone to school longer than almost anybody, and you're paying him $8 an hour. And so, yeah, you're going to create a doctor shortage, and that's going to put upward pressure on costs as well. So, yeah, and I think part of that is you can kind of tie the two issues together, is that you don't have competition among schools right now, and so you don't have schools competing to lower costs for med school, which is a problem. So.
Take one
All right.
more.
One more? Okay. He put his hand up a bunch of times, so I got you.
Suppose we instituted all the solutions you said we did, like everything we could conceivably do, and we lower prices by like 50%. We're still dealing with several $1 trillion. Like, how is it like worth our time almost? Is it like inevitable that we have a huge debt crisis?
Inevitable? No. Likely? Yeah. To be frank, because if you look at the economic incentive structures that are created by these programs, you create a constituency. What Obamacare has done is promised millions of people that free health care almost. And when you try to take that away, that's a very powerful voting bloc. So that's the problem. You really need courageous politicians that are willing to say, well, you know what, I'm going to have one term in office because I'm going to do the most unpopular thing in the world that has to be done. I mean, we're seeing, this is exactly what's going on in Europe. I mean, almost exactly what's going on in Europe. And despite what the economists try and tell you, like Paul Krugman or whatever, they try and tell you that this is an austerity problem. No, there hasn't been austerity in Europe. They still have really huge government involvement in all of these sectors. I mean, in Greece, you can retire when you're like 50, and the government pays like over half your pension, if not 90%. And so that's kind of the same thing where you have these huge entitlement programs, and those create constituencies that are very hard to fight. None of this is inevitable because all those projections I just showed you are under current law, and the law can be changed. It's just a matter of really being brave enough to tell people, like, look, I know you're scared of, this is something that gets pulled on guys all the time. Paul Ryan was a victim of this when he instituted a plan to fix some of these things. And they showed a commercial of him pushing a grandmother off a cliff because he wanted to restructure Medicare into a voucher system. And it's basically, they're saying, don't take away my Medicare. Well, Medicare is going to take itself away from you if we don't do anything. And so we're really you have to really convey the message. And this is why young people need to get out and vote, because none of these programs are going to benefit you. You're probably not going to see much of a return on investment for Social Security, Medicare, and Medicaid. You have to remember that entitlement programs, when you pay into them, that money goes out the door that day. There isn't a pot of money with your name on it for all the FICA payments that you're making. Right? That's going to pay for current people. And just one final thing on that, Social Security, when it was founded, had upwards of 15 people paying for one retiree. We're down close to 2 because of the aging population. So it's about young people. Get out and vote.